Thank you so much for joining us at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by the Center for Substance Use Training and Telementoring, also known as CSTEP. My name is Andrea Roche. I'll be facilitating our discussion today. I just have some housekeeping notes before we get started. As you saw, this session is going to be recorded and made available afterwards on the Be Well Texas YouTube channel if you miss anything. Anything you list in the chat is not listed on those recordings. This session is also enabled for live closed captioning. If you want to view that for this session, just navigate to the bottom of your Zoom window and select the Show Captions option. You might need to click on the three dots or the More menu at the bottom right corner of your Zoom screen to find that. If you're having any trouble accessing it, just chat Kato with UT Echo IT directly. Many of you are already doing this. We appreciate you helping us out with attendance. Everybody else who hasn't, please use the chat feature to enter your name, your affiliation, and your email. To access that chat feature, just go to the speech bubble icon on the bottom of your Zoom window. And if you are a Be Well Texas provider, make sure you identify yourselves during this session so we can give you credit for being at the session. If you're joining by phone only, I don't think we have anybody doing that. But if you are, make sure you email that phone number and your name to the Be Well Texas team at bewelltx@uthscsa.edu. We'll throw that email into the chat just to make sure we give you your credits for being here. We encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you've joined us today, we're happy you're here to learn alongside us. There are a lot of people coming to this session, and I'm happy to see the number keeps creeping up. So please do stay muted unless you're speaking, but we also encourage you to speak. If you've joined by computer, that mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6 to unmute. You can also use the chat to share your perspective. And so there are a lot of us in this space, so please do make sure you keep your comments brief to allow others a chance to speak up as well. But know that whether you're unmuting and speaking or sharing information over the chat, no protected health information is allowed in either space during the course of this session. Towards the end of the ECHO, the Be Well Texas team is going to send out a link to an evaluation survey. Fill it out to give us some feedback on how to move and refine and shape these sessions moving forward, and also to get access to the approved CEs for paramedics and any public safety professionals with a behavioral health degree. The other reason to fill out that survey is it enters you into a drawing to win a $30 Walmart gift card. We really appreciate your feedback. So keep an eye out for that link about 3/4 of the way through the session. I'm excited for our conversation today. We're going to start with a presentation on crisis intervention training for substance use incidents presented by Nick the Cop. And following that, we will hear a case presented by a member of law enforcement that I think nicely ties into some themes from that presentation. There are a lot of professions represented here today and a lot of experiences, a lot of perspectives. So I encourage each of you to share that during our discussion so that we can see into each other's professional lives a little bit more and learn from each other in this space. ECHOs are known for being a setting of all teach, all learn, and that only happens when all of us contribute. We're going to start the session with some introductions to our hub team, then get into those didactics and the case. So let's start with you, Dr. Miramonte.
Good morning, it's Dr. Dave Miramontes. I'm the medical director for the San Antonio Fire Department, and we do a lot of buprenorphine treatment and substance use disorder care in our mobile integrated healthcare or community paramedic program.
Great, thanks for joining us. Cynthia.
Good morning, my name is Cynthia Mendiola. I am a retired probation officer. I work training and coaching other probation officers across the country in core correctional interventions.
Thanks for joining us. Jeremiah.
Good morning, everybody. I'm Jeremiah Golka, Executive Director of the SHIELD Training Initiative. We do occupational health and safety training for police officers, EMS, and other criminal justice professionals, especially as it ties in with the overdose crisis. Looking forward to the conversation.
Thanks, Jeremiah. And Joe.
Hey, I'm Joe Smaro. Proudly resigned San Antonio police officer from the mental health unit and current CEO owner of Solution Point Plus, which is a national training and consulting firm that specializes at the intersection of criminal justice and behavioral health. Happy to be here. Excited for the session.
Thanks so much. Andrea.
Hello, everyone. My name is Andrea Havler, and I am the program coordinator for CSTAT. I'm happy to be here.
Thank you, Andrea, for joining. And our case today is going to come from Sean. Sean, would you mind unmuting and just introducing yourself to the group?
Hi, my name is Sean Kincaid. I am an officer with Arlington Police Department, and I work within our behavioral health law enforcement unit.
Great, thank you. And thanks for sharing the case for today's conversation. Let's go over to the didactic. So Nick Margiotta, you'll be presenting today. Please do introduce yourself while Kato's pulling up your slides. And when you're ready, take it away.
Great. Hi, guys. Hi. So I'm Nick Margiotta, retired Phoenix Police. For about 10 or 12 years, I ran the Phoenix Metro CIT program. So a captain there with about 4.5 million folks, and was kind of the de facto liaison between law enforcement and the behavioral health system in Arizona. Served on CIT International's board, was the CIT board secretary for many, many years. And so been very involved in the space. I've obviously been to Texas a few times. And ironically, I actually have a CIT related training going on in Austin this week. So some of my team's out there doing that as we speak right now in Austin. And had the pleasure of being at the CIT conference in San Antonio many, many years ago. So I saw somebody who was from Bexar on the list. So had pleasant memories of that. I'm now retired. I do consulting. Fortunately, most of my consulting is towards the behavioral health side and the managed care side. I don't consult a lot directly with law enforcement. I did my 20, and it was a great experience, but now I'm kind of playing in the different side of the pool a bit. So with that, let's just jump right in. I think we can go forward a couple slides to where we get the content. Yeah, one more. Oh, look at that. That's fancy the way that's fun. I don't know when I built that neat transition there, but so I feel like I'm sure many people have heard of CIT. It's probably no big surprise to most of the folks on this group that folks, especially law enforcement, but obviously fire as well, fire EMS, right? We have a lot of interaction with individuals with behavioral health needs. They're clearly overrepresented in those interactions, which historically has led to being overrepresented in the criminal justice system, right? Whether that's jails, prisons, whatever that might look like, and certainly frequent contacts with phone, repeat calls for service, things of that nature. And part of where that stems from is historically law enforcement was a law enforcement criminal justice entity, and so as this phenomenon continued to increase, law enforcement historically responded with a criminal justice interaction, which led to the overpenetration in jail, criminal justice system, things of that nature. And sadly, in many communities, I won't speak specifically to your community, but I do a lot of national consultation, so I see it in many communities. The community behavioral health crisis system is inadequate. And so what ends up happening is you see law enforcement and fire and EMS becoming the de facto community behavioral health response, when in reality that was never the intent and is not the right answer. And then unfortunately, as we saw over the past several years, then folks kind of were very unhappy with how that got responded, where I always went back to for years, well, why are we expecting police to be the behavioral health response to our community, right? They're a part of it, but there is this broad community behavioral health system in our country. It needs to evolve. And ironically, you're starting to see a bit of that evolution over the last 3 years, largely tied to 988. This isn't the time or place for me to go into my 988 presentation, but that's basically the national equivalent of 911. And so the idea being nationally is folks have another number to call when they actually don't need police, but they need something, and it's behavioral health related. And so that's starting to drive the conversation nationally. Part of, we're going to talk about CIT here today, and then obviously that will pivot into substance abuse. But, the idea behind CIT, crisis intervention training, is, truly is a collaboration. So if we were in person, I would kind of do a show of hands, or I'd ask who represents who. I'm almost afraid to ask folks to do it on the reaction screen because I know I'm not capable of doing that. But if it was possible, if you could do that little reaction thing, just to say if you kind of identify from the law enforcement or the criminal justice side of the equation. And if that works, we'll do that for the other constituencies. If not, I'm just going to ask Andrea to give me a sense of who might be on the phone. So if you identify as kind of law enforcement related, if you could do the reaction hand up thing.
And to navigate to that, the bottom of your Zoom window, really, you should see a reactions menu and you can either raise hand or do a high five or.
Or
Maybe-
give me another finger if you want. That's fine too. Any finger will do. Well, I know there's some cops just to introduce themselves. So, okay. So, Andrea, I'm just going to ask you, since that's not obviously working. So, do we have a sense, like, of the 36 folks, about what would you say represents law enforcement in some shape or form?
Man, I don't know if I can answer that. We have a pretty good blend of folks who join these sessions. I don't think that makes up the majority though. So
Okay.
I think you're probably looking at the 10 to 15.
Okay.
Yeah.
And then it looks like we have fire and EMS in here as well, correct? So is that a similar representation?
Yeah, Andrea, does that seem strikes true for you too? Yeah.
Then I saw some hospital folks, some counselors, so I'm guessing we have a fairly large behavioral health representation.
Yep, behavioral health and peers also joined this too.
Okay, so that's what I was going to ask. Do we have family, peer, consumers, advocates?
Yeah, the peer and the recovery workforce. Yep. Here too.
Perfect, great. Well,
We're a good group of folks.
Well-
Dr. Monte, you were going to chime in too.
Also, corrections and probation are included.
perfect, yeah. And for simplicity, I'm just going to blend it into criminal justice. I know it's different than law enforcement, but we'll just kind of blend that in. So perfect. So you've got the triad, right? That's kind of what the triad is. It's your public safety or your first responder. It's your family, consumer, advocate, peer, and it's your behavioral health. So you basically have the triad of what a CIT program is about. So I think we can go to the next slide. It's more fun when we do that in person. So I apologize. So many of you may have heard of CIT or crisis intervention team training. Probably the law enforcement's a bit more familiar with it than some of the others, but it's been around for a while. The challenge with that is most folks really don't understand what CIT is. And so I think it's very important to talk about what CIT is for a few minutes, just to kind of put that out there. And I served on the board for a long time. If you're familiar with it, it's basically based on the Memphis model. Sam Cochran was the Memphis officer who created it back in 1988, I believe. And I used to tell Sam, we served on the board, I'm like, why did you call it CIT? You're confusing everyone, Sam. You should have made it CIP, a crisis intervention program. But everybody thinks the T stands for training, and it does not. It stands for team, crisis intervention team program. Training is a component. Unfortunately, it's not what a CIT program is. And so to help kind of bring that through, we kind of tried to come up with this vision of a five-legged stool to help folks understand what is CIT. It is partially law enforcement training, and it could be for corrections. Obviously, they attend. Fire and EMS are seeing becoming more involved with it. But for simplicity, it's rooted for obviously in police and sheriff. And it's in its pure form. It's a 40-hour voluntary training. It's advanced training for officers to understand the behavioral health system, to understand recovery, to understand diagnosis, to learn intervention strategies and things of that nature. Ideally, it is community instructed, right? It's not me or another cop teaching most of it. Clearly, the cop needs to be part of it. They should be facilitating it. They should kind of weave in and out. But the presentation should be largely provided by the experts in your community, probably folks like you, many of you on this call. And so that's why we talk about that partnership, is having those folks with lived experience, those who work in crisis, those who work in the health system, come in and be part of that instructing to help do that. It's an important component, but it is only one of 5 legs. And unfortunately, in most communities, it's what people think and talk about and say, yep, we train those damn cops. We got CIT. I'm telling you, if all you're doing is training the law enforcement around this, you do not have CIT. And frankly, you're really not moving the needle, because the idea is it's about a program to kind of change the way we interact and folks receive care in the community. The second large leg of this is community collaboration. We talked a little bit about the 3 main constituencies. They work together. They should be working together for the training. They should be working together for solutions, for partnership, for resources, for what crisis services can look like, a variety of things, right? But that partnership is really where the crux of CIT comes from, right? The third leg is my most passionate leg. I could spend an hour just on the third one. I won't, but I could. And that's having a vibrant, accessible crisis system. I know some communities across the country have that. I know some communities in Texas have that. I know several communities do not. Every community has a crisis system, but the reality is how accessible is that? So what we've landed on with this is this concept of no wrong door approach. If law enforcement or fire and EMS, for that matter, run into somebody having a behavioral health crisis, they should be able to hand somebody off to a community-based crisis solution. And the response should be yes. It should be that simple. It shouldn't be, well, do they have Medicaid? Which insurance do they have? Is substance abuse a factor, or is it just mental illness? Or is it both? Or are they suicidal? Or are they friendly? Or do they smell clean, right? One of my favorite, we actually had a crisis detox facility, and we were touring some folks, and they're like, yeah, well, what we hear is they're not drunk enough, so they're not going to accept them. To which I started to laugh, and being irreverent as I am, I was like, well, that's an easy solution. If my crisis facility told me that they're not drunk enough, I'll just bring the guy to 7-Eleven, buy him a 40 and bring him back in 15 minutes. Shazam, now we'll be drunk enough. I mean, those things can't be the barrier. The answer should be yes. And so when I talk to my behavioral health friends, I say, don't me. Don't do utilization management at the front door of crisis. You can certainly do all those things behind it. It may not be the best solution where they've arrived. You guys as a system can help coordinate and get them to the right place. But if law enforcement and or fire and EMS are making that handoff, the answer should be yes. And so what that really means are expedient, quick handoffs. So from a facility-based solution, that's 15 minutes or less. When they show up in the door, they knock on the door, push the buzzer or whatever, that facility should accept that person within 15 minutes and then free them up to go back to doing public safety while the behavioral health system takes over. If it's a crisis mobile solution, the answer should be yes, we're on the way, we're coming now. We get there. As soon as we get there, we find out what's going on. Assuming that the situation is, objectively safe, we release law enforcement from the scene and we take over and we do the intervention, right? We don't expect law enforcement to sit there for an hour and a half while the behavioral health team is doing an intervention. Now, obviously, if there's an objectable danger, the guy's swinging a bat, that's a different story, right? But the reality is, rarely is law enforcement going to introduce civilians into that scenario until it's safe enough for them to be there. This sounds really like sexy and really easy to do, but it is challenging, right? I mean, there's things that have to be in place to get there. A lot of folks want to get medical clearances before they'll accept folks, and all of that basically kills the idea of no wrong door. The other part of this is, ideally, this is not a hospital-based solution. This is a community behavioral health solution. This is preventing folks from hitting the EDs, right, and or inpatient solutions, because that creates a whole other system challenge. So that's where that accessible crisis system is. I could spend another hour on it, but I won't. The next part of CIT is, it's great that we're training the law enforcement, criminal justice team, or fire and EMS, but behavioral health providers also need to be trained to be part of the CIT program. They need to understand the law enforcement perspective, that culture, what those expectations are. Lots of ways you can do that. What we created was a training we called Cop Culture 101. And the idea behind it was, here's what your average cop's going to look like. Here's what they're expecting. Here's kind of how they're approaching it. So when they're making a handoff, these are the things to be aware of. Not because, oh, great, we need to say kumbaya for the cop, but so that we understand their perspective, their culture, and now we can more effectively work together with it. Some communities do ride-alongs. They expect their crisis providers to do a ride-along with police so they can see the other side of it. In our community, especially when I was still there, every one of our crisis mobile, our crisis phone supervisors, and the folks who worked at our crisis facilities that would interact with law enforcement were required to go through this training. Just like we were getting law enforcement to get trained, the behavioral health system also needed to be trained. And then the fifth leg was education for families, advocates, consumers, peers, things of that nature, so that they understand it better. They understand the realities, right? Diversion will not always happen. Sometimes folks go to jail. Sometimes folks need to go to jail. Sometimes there's no discretion around it. Most communities are required to do enforcement when domestic violence is in place, right? Things of that nature. The other thing we would teach families were, hey, if you're going to call for law enforcement, one is request a CIT officer. You may or may not get it, but You can request that. The other thing you might consider is if you want to tell me some information about your loved one, the best time to do it is not when I'm walking into your house and your loved one's in the throes of their crisis. At that point, I'm focusing on that, right? I'm in my house now. Meet me 2 doors down. Come out there, give me some information, give me some tips on how to best engage your loved one, your son, daughter, uncle, whatever it may be. Do it there in a place that's safe for you, safe for me. I can get that information. And then as I go to approach the scene and interact with that individual, I'm better informed. But if you wait till I'm at the front door and somebody's screaming, yelling, and doing something, you've actually become part of the problem, not part of the solution. And so sharing that information, we used to do that at the, I used to present for the NAMI family to family classes, things of that nature. When you put these together, those 5 pieces are what CIT is. It's not about training the cops. It's only one of 5 components of it. And so that's a systemic approach towards approaching it. And when you hear CIT, that's really what we're saying. And not just training the cops, but we need this entire system to get aligned, including the crisis system. So we can go next slide now. So it's great to talk about crisis. I can do it all day. The reality is that leads to frequently, when done right, will lead to a good immediate solution, right? But it really is a Band-Aid. Let's be honest, right? When we're doing a crisis intervention, even when we're doing a crisis ER intervention, right? It's a Band-Aid. It's what do we do now? It's not the long-term services and solutions that are needed to help folks get into recovery, right? That happens outside of the crisis. And what we find is basically we've created a revolving door to crisis if we don't have follow-on services that are available and readily accessible, right? So folks face all kinds of barriers. Probably most of you are aware of them, right? Folks get cold handoffs, you don't have the right insurance, there's long wait times to get appointments. Folks are anxious. I mean, just think about yourself. If you've ever gone to an ED, they're now, releasing you after your 8-hour wait. They see you for 15 minutes, they give you a stack of paper and they tell you to follow up with your PCP. How many of us actually do that, right? Okay, I got the problem solved and we're done. So all of those issues get in there. The other one that's large, especially in behavioral health window, is that window of insight, right? There's sometimes a narrow window of insight for folks to actually say, yes, I will engage. And if it takes weeks to connect folks to service and treatment, we basically miss that window, right? And unlikely are we connecting into those long-term solutions that are needed. This is super relevant when we're talking about mental illness. It's uber relevant when we talk about substance use. Next slide. So in Arizona, we have a pretty robust CIT program. It does have all 5 legs. It's got one of the nationally best recognized crisis systems. But obviously, there's still challenges and weaknesses. We have significant opioid problem. I'm not going to go over these data because every one of you is going to say, yeah, we have a significant opioid problem too, right? Everybody does. It's a huge issue. We were about double what the national rate is, but I feel like everybody's double. So I'm not sure how that rate gets there. So you can go next slide, but we clearly had a large issue involving substance abuse. And so what we did was we went after a grant. This one happened to be with the city of Tempe. It's a university town. It's got ASU in it. It's about population of maybe 250,000 folks, but when you layer in the university, it gets close to about 300, 350. And ironically, a very progressive police department who did not embrace having their officers carry Narcan. They were actually either the last or the next to last department in our region to carry Narcan. So they were very slow to carry Narcan, which was strange to us because again, they really usually are a very progressive department. So we met, we talked about this grant opportunity and what it was twofold. Part of it was to get Narcan into the hands of the officers, which it did, it accomplished that. But the other hand was like, we need more than that, right? That's a Band-Aid. It's going to save a life, right? I mean, I have this stuff laying all around my desk, right? We got Narcan coming out our ears now. They're all the nasal ones, right? But it's going to save that life. We get it. It's important. But what's going to happen tomorrow, right? Am I just going to have to save that person's life tomorrow? Is fire going to? What do we do? So we kind of embedded it with that crisis response, but then that post-crisis navigation, that solution, that peer to do that follow-up. So next slide, please. So the idea behind this was, we built it on the concept of what CIT is. We're not expecting our police officers to be the behavioral health solution for our community. Neither are we really expecting fire or EMS. They're the emergency response. They're going to touch stuff. They should be the nexus to that system hand it off, go back to being public safety and having the public behavioral health system take over and do everything thereafter. And so the idea behind it was, let's equip our officers with Narcan, obviously fairly easy to do, especially in today's day and age. But then when they administer, or fire would administer, we then had them do a super quick, easy referral process. And literally it takes about 30 seconds for them to do it. So it's built off of those same precepts we talked about, like accessible quick crisis system. They had access to a 24/7 crisis line that impact a behavioral health provider in our community. They run the suicide prevention lifeline, things of that nature, operate, and they would give 4 quick pieces of information, person's name, where it happened, what hospital they went to or whatever, and if there were any safety considerations, right? That was it. It took about 30 seconds. The officer was then done. That then triggered a crisis response from a behavioral health person who usually would be a peer, somebody in recovery, because we found much more effective engagement with folks. And they would respond within an hour to that person, that window of insight. Law enforcement's already left. Usually the person's in the hospital, but not always. And then we would connect with that person, engage, build some rapport, give them some more Narcan, and say, can we work with you? You were dead an hour ago. Can we follow up with you? Can we support you? Can we help connect you to services, treatments, provide transportation to appointments? Ironically, what we see a lot of the stuff being were really those social determinants of health. Most people didn't say, yes, I'm glad to be alive, start me on MAT, or go take me to IOP right now. I want it, right? Happens, but rarely happens. Usually what would happen is folks would focus on those social determinants of health. We would lean in, have our peer support work with them, help be that facilitator or that navigator to getting those services. And lo and behold, kind of like Maslow, as those things started to get addressed, folks were much more amenable to working into treatment. Next slide. And what we found from it were frankly staggering. It blew away our expectations. We far exceeded all of our expectations. Law enforcement is now, in that size community, is almost administering 100 times a year. Significant. We anticipated about 40, 45. And of that population, it's a challenging population, right? We're talking about folks, about 75% of them meant to use an opioid. About 25% did not. They were doing marijuana, cocaine, whatever it was, and then it was laced with fentanyl. Well, I just got a surprise. But anyway, you look at it, almost all of it was somebody who was intentionally taking something or abusing their pain pills, right? So a tough population, and around a little bit more than 50% of them agreed to some supportive services, right? That sending that peer out within that hour, releasing law enforcement from this, so making it not putting the burden on police, it connected with folks, right? They engaged. We obviously distributed a bunch of Narcan and everything else, right? But it also helped us to overcome, we weren't really sure what was law enforcement going to do. Were they going to do it? Were they afraid to use it? Well, we found that they weren't afraid to use it. They actually used it much more than we anticipated, and frankly embraced it. And we do think part of why they embraced it so much was this post follow-on care that we also built into the program. I focused a bit on law enforcement just because that was kind of where the grant was written, but it did have that collaboration with fire and EMS. So if fire and EMS administered Narcan as well, that would also be the trigger to dispatch this service. Logistically, it worked out that fire wasn't willing to make the phone call, so they would tell the police officer, because the police officer usually rolled on scene as well, even when fire administered, and then the police officer would call the crisis line and trigger that response. But it was available whether police or fire did it. And the idea being is it triggered that response, and it didn't expect law enforcement to be the follow-up solution for it. It expected behavioral health to be the solution because it was a behavioral health need, right? So I feel like that gives me about 12 seconds before I hit my time. So I think we could probably minimize the PowerPoint if you wanted and see folks again. And happy to answer any questions if you have it. I think we have a couple minutes reserved for questions. Is that correct, Andrea?
Absolutely. Great presentation. And let's open up the room for any questions for Nick about that presentation. Might go without saying, but you mentioned at the beginning of that SAMHSA program, before it started, the officers were hesitant, did not want to carry Narcan. Can you speak a little bit to how the successes you all saw maybe contributed to some culture change, perspective change?
Yeah, it was palpable. ASU, Arizona State University, was actually the evaluator. They did a very lengthy pre-survey before we started the training. They then did a 90-day post after the training in the administration. Amazing changes of perception. But I still remember the first or second day we had just trained the first group of 4 officers or 6 officers. One was a sergeant. Typical to cops, right? You're getting a lot of this. They're joking about it. Yeah, right. But in the reality, we knew that a lot, cops aren't going to stand over somebody and watch them die if they have a solution. And so, our policy was going to be they had to carry it on them, blah, blah, blah. Well, of course, it's the first training. Nobody did. And you can hear the radio when we listened to it. You can hear the sergeant, who was kind of crusty and a pain in the neck in the training, go, I need some of that naloxone stuff. We need it now. We need to get it here. You can hear him. And then the guy runs up and you watch because they're all on body camera. Of course, he doesn't have it on his person like he was supposed to. And you see him going through his bag frantically, panickingly, looking for it, finding it, running, administering it, and watching the person come back to life. And it was like, oh my God, like you could just see, and fire was still en route. Fire wasn't there. And you could just see it. We then used that video in every other training, and it was magic. We never had an issue with folks carrying it. We never had folks like kind of saying, we're not doing it. There's something magical happened when they saw it work, saw it was the solution. It really took hold very quickly. And the other thing we found, I don't know if Texas saw it as much, but during COVID, fire, and rightfully so, they would get significantly prepared in their PPE before they would go on scene. And it was only a few months before we started that COVID hit. And so what we saw was fires times were taking longer to get there. And law enforcement's administration, they would just go with a mask, right? They weren't doing the entire PPE stuff. Law enforcement's administration spiked. Now it's kind of now settled back down, now the crisis, COVID crisis is kind of abated, but we actually saw law enforcement actually becoming the primary administrator of naloxone there for a while during some of COVID. So it was an interesting dynamic. I do think it helped quite a bit that we had law enforcement teaching law enforcement about it, right? So our Narcan coordinator was an officer, he had a lot of credibility. He was a 20-year officer, he was a negotiator. Folks bought in, it worked, and they definitely loved the fact that the behavioral health system was doing something afterwards. It felt like they just weren't doing a revolving door, and it's a mental thing, right? But they're like, yeah, I'm saving the guy. Yeah, he may come back tomorrow, but I know somebody's trying to break that cycle. That was actually quite powerful. And that was one of the key things that really, I think, helped law enforcement buy in.
Yeah, I can imagine it's empowering knowing you're not having to do it alone over and over and over again. We got a lot of questions popping in the chat. Kato, thanks for sharing that last slide. Nick, if you're comfortable sharing your contact, a couple in the audience have asked for it. We also have a question. Kim asks, is there a model for the CIT program that we can share with local law enforcement?
Maybe do you explain that a little bit? So to me, it's the CIT model. It's that there, but maybe give me a little more idea what you're thinking, and maybe I can give you a better answer.
Yeah, Kim, you want to unmute and share?
Yeah, so if we wanted to introduce this to the local law enforcement at county commissioners meeting or city level, how do we replicate this, or can it be replicated?
Yeah, good question. Yes, I think if you can replicate it easily. We're in year 3 of our 4-year grant. We actually did just apply for another one. We're waiting on SAMHSA. They haven't announced. But the reality is a lot of this can be funded either through county or Medicaid dollars. About 70–80% of the folks we're administering Narcan to at the end of the day are Medicaid eligible. So that allows some of the behavioral health response. It seems like states are tripping over Narcan, right? I mean, I don't think there's a lack of Narcan in the community. So yes, I think there's definitely ways to replicate it. It does have a cost, right? Obviously, but breaking that cycle, reducing calls for service also has a cost. grant funding is wonderful, right? But grants are always a mixed blessing if you're in, if you're coming from an administrator side. So building that sustainability is key. But what we're demonstrating is return, repeat calls for service. Obviously, repeat use of the hospitalization, things of that nature, and then building Medicaid where we can, building that structure to help minimizing, or your county, depending upon how I know Texas works from a county district level. So building that for the uninsured to kind of help support that. To me, the salient points are you build it off of the back of CIT, but a true CIT model, right? And we don't expect law enforcement to be the own it all. They're the nexus. It's a public health situation. Public health has got to be that second stage, right? That to me is the two keys with making it sustainable and replicable. I know some programs they send the cop out the next day to go do all the follow-ups, right? How much do we want law enforcement involved in doing public health? They're going to catch it. They are the front door. We get that. But once it's safe, it feels like that should be a public health process going forward. So that's really how we built it around that, right? It's a dyad, but it's a very collaborative dyad.
Great. Thanks so much for that. A really thorough response. And Kim, I want you to see also over in the chat, a couple other resources have been mentioned. Jeremiah put something in from the National Alliance on Mental Illness. And Sean also recommends resources that can be found through CIT International and the International Co-Responder Alliance. Cynthia, I saw your hand just a bit ago. I wanted to come back to you.
I wanted to ask a question. I think this is piggybacks off of Ms. Williams, and I'm wondering, when you say we, are you talking about the behavioral health system, like the public health system, like for example in San Antonio, the university health system that would initiate this this program, the CIT program, and then start collaborating with partnerships?
Well, San Antonio has a very large, robust CIT program currently, right? And then you even have the campus there, don't you, right? And you've got that large crisis facility campus, things of that nature, right? So I would say you use that as the foundation for the conversation. This is obviously slightly different because it's going to be more opioid and substance related, and you need that follow-up service. But I would build it off that foundation and that relationship. And then remember those precepts of what, it's quick, it's easy, there's a nexus, and then we build a solution to respond to that, right?
So what if we have communities that don't have, a robust crisis intervention type of, startup? Who would be the driver of something like this?
So in Texas, it's going to be your region, right? You got your district, you got your 43 districts or whatever you have there, right? You're seeing a lot of that happening now because of 988, right? 988 is pushing this. They're going with either the Crisis Now model or the SAMHSA best practice model, someone to call, someone to go, someplace to take them, right? You're seeing that. What you see, though, are a lot of providers who won't do it. They don't want to go out at night. They don't want to go talk to people they don't know. They don't want folks coming into their facility who might be drunk, right? So what you've got is, some states are doing it well. Some regions are doing well. San Antonio, Harris, obviously, there's some that are leaders. There's a lot that aren't leaders, right? And they've got these challenges. If you don't have that, you don't have CIT. You don't have that. You really don't probably, pragmatically, have law enforcement really at the table meaningfully because they don't have a solution. And so they're not, right? They need to see some solution based with it. I would argue that's your first step. When you can build that, then then doing specialties is a natural segue after that, right? But if law enforcement doesn't have someplace to go other than the jail or an ER, and an ER that might be difficult to work with, that's your bigger challenge right there.
Thank you. That helps a lot.
I think we have time for one or two more questions. Deanna raised in the chat, what are your thoughts on CIRT, the crisis intervention response teams or co-responder models?
It always comes. So I will try to be diplomatic. So there's a time and a place for a co-responder. A lot of communities like them and embrace them. My personal opinion around this is, if a community behavioral health crisis system is doing their job right, like we talked about in line 3, and literally I could spend an hour on what that looks like, then you don't need a co-responder because your community behavioral health crisis system has built the infrastructure that solves that problem. Law enforcement are out with someone, they see it, they're like, this person, This really isn't a cop call, it's a behavioral health call. They trigger it. That team responds very rapidly. It's a 2-person team. Officer says, I just was talking with Andrea. She was upset. She's crying, but she's not swinging a bat. You guys got this? They say, yes. I go back to take a bite out of crime. They take over the intervention, right? When you have that, the co-responder doesn't really have much more to offer to that, right? Because generally in a co-responder, one of the two people will be underutilized, right? It's either going to be more violent, more safety driven, right? You're going to need your officer to help safety you, or there's not a huge safety concern or not a huge concern after all. So then behavioral health needs to be the bigger player, right? And then there's an economy of scale. Now, what you see is very few places in the United States have what I described. And so for more than a decade now, communities have been creating their own solutions to try to come up with a solution, which was in many places a co-responder, sometimes completely funded from the public safety sector, with public health not even being at the table, right? So they've come up with a solution to a problem. I would argue it's an iterative step towards a long-term goal of right-sizing the public health system, using law enforcement as a partner and a collaborator in it, but not putting the burden of that intervention always on law enforcement. So it's a yes and, in my opinion, right? It's hopefully not your end goal, but it might be your intermediate step while your community is evolving to it. In the Phoenix metro area, there are something like 2,000 crisis mobile team responses a month, something like 32 teams or something ridiculous like that. Less than 10% of them have a law enforcement officer on scene. 90% of them happen without any law enforcement involvement at all. And then if law enforcement finds something, they'll call for the team to come. They come, they release law enforcement, and then they go, right? Unless there's an obvious safety issue. So it's an iterative step, but some folks have gotten lost on the iterative step, I know.
All right, that's really, really helpful, Deanna. Great question. I do want to move to the rest of the content for today's session. Keep the questions coming. Nick, keep an eye on the chat and try to answer what you can. I know your time with us is a little bit limited. We would
We've only
appreciate
got a couple minutes left. I'm sorry.
Yeah, if you're comfortable with it, throw your contact over in the chat. It sounds like
Yep, I
plenty
did.
interested in connecting with you.
Let's Thank you guys for putting up with me.
Thank you for the presentation again. Let's go on and do some announcements from CSTAT. So if you don't know, the Center for Substance Use Training and Telementoring, or CSTAT, provides high quality education and best practices for responding to substance use. CSTAT can help enhance professionals' knowledge and self-efficacy to screen, to treat, and make referrals for people with substance use disorders. Learn more about this great program. Visit them at c-stat.utesca.edu. We'll throw that link over into the chat. Next slide. And we hope to see you all at our next month's session for the Public Safety Echo on Thursday, August 10th. We'll be discussing overdose recovery centers with a focus on medication-assisted treatment and emergency medical services. All right, let's keep things running. We're going to go to you now, Sean. You have our case for today. Please do screen share when you're ready, and then talk us through this case and questions you have for this audience assembled today.
Thank you. Let me pull this up. I don't use Zoom very often.
Not a problem.
Is that working?
See, I don't see anything just yet. There, it's starting.
Okay.
Go ahead.
This was, I want to say 4 or 5 years ago, where we got a initial call of a subject. He was 20 to 30 years old, was on top of a 3-story apartment complex building with a propane tank, stating that there were, he had very, highly delusional with the fear and paranoia that people were out to get him. They were in this building, and that his goal was to burn it down. And so that was kind of the first, call text that we get for what is going on. We were able to, fire and EMS showed up as well. We were able to actually de-escalate that situation and get him down off of the building. And through speaking with him and kind of the follow-up that led to that, we found that there was a lot of unaddressed mental health issues, as well as substance use issues that exacerbated a lot of those. And so this was prior to us having a actual behavioral health unit. We had officers in the field that were ancillary behavioral health response officers. so kind of with what we had, we did the best we could to follow up with this individual, you know, and to make sure that this was something that we could try to stay on top of, you know, because obviously we don't want that to happen again. Some of the stuff that we ran into, we found that his substance use was from methamphetamine. We found that a lot of the stuff that we kind of ran into with him was that there was a lack of familial support, inconsistent, stable housing, and employment, you know, having consistent employment. What we found was the substance use was secondary to his behavioral health issues, and that he actually used the substance as a solution to his issues. He cited that it helped with sleep and to protect him from the fears and paranoia that he had. But he did have a little bit of insight to know that that also made it worse. We also learned, in not a ton of detail, that there were several ACEs in his past, adverse childhood experiences, that kind of contributed to where he was at that time. This was also right before COVID. So kind of the follow-up with him was it went well, and then we hit that roadblock kind of like everybody else did at a certain point, where services started kind of closing their door. Everything was over phones and computers. One of the issues we ran into with him was he had the paranoia of being tracked via technology, unless it was a phone or computer that was used by us. So any type of follow-up, whether it was court, whether it was counseling, therapy, doctor appointments, was very difficult at that time. And so we kind of tried to become case managers, in a sense, to help him get through not only the legal system, but addressing the behavioral health and substance use as well. And at times, you know, we even worked with his apartment's management to keep, you know, him housed and to not have them evict him and try to kick him out and keep that situation as manageable as possible. Long term, to this day, you know, we were able to help him stay off of substances for just over a year. Recently, that's kind of declined, more so because there is no stable housing anymore, and keeping track of him without a good point of contact is a little difficult. But the good thing was what we did is we set up basically a point of contact. The lieutenant over our behavioral health unit now kind of became that go-to, where he would walk up to our station, our main station, or call her, and would know that, you know, he would still have these delusions and paranoia, but knew enough to say, I need to just come talk to you. And what it kind of turned into was this like brief solution focused therapy. Right? You know, tell us what's going on. You know, tell us some of the things that you're experiencing now, and let's address today and try to get to tomorrow. And we kind of just took it day by day, week by week, to help him as much as we could. I'd say that with our unit now, we would have been able to dedicate a lot more people and a lot more time to the issue. Being the officer that was assigned that area, we work with our local mental health authority to do follow-ups for any calls that are, you know, mental health related. But getting out there as a patrol officer, you could set a time all the time you want to try to go out there, and then there's times that it just doesn't happen that day. So it became difficult trying to build a consistent relationship with him so that he could recognize you as, okay, you're Officer Kincaid, I've seen you, you've come talk to me, rather than you're just a police officer that happens to drive by. So that was kind of what we did. I'd say some of the roadblocks we ran into, especially in the area that I work, um, outside of COVID substance use treatment, we run into issues where they'll treat the substance use, but not the behavioral health, and then vice versa the other way. And we're never kind of attacking this at both sides at the same time. And then the other part of that is trying to find affordable or free, in that matter, type of therapy or counseling prior to being convicted of a crime. That was one of the things that we, as we go along, we start learning more and more of the parts that PD is never normally a part of, but you start learning that back end, which obviously led to our unit being formed. But, finding out that there were a lot of services that were free, but you had to be convicted of the crime first. You had to go through the legal system and a judge order you to do, certain treatments. And what we were trying to do is get that prior to them being in a situation where an arrest was going to happen, which kind of can have that domino effect of, if they do work, if they have doctor appointments, housing, where it can kind of affect all of that. That's still something that we are, working through. Obviously, we can't force anybody to give out free services, but it's definitely something that we work with a lot of resources in our area and collaborate the best we can, to get people the help that they need. I'd say here, one of my questions, especially like up in Tarrant County, harm reduction groups seem to be, they're there, but the ones that I have reached out to don't quite provide the resources that we're kind of looking for. I understand, getting people products that they need to be safe, with their day-to-day lives, is always a necessity, and that's something that is greatly needed. What we run into again is the treatment that is quick, where we can get somebody in based off referrals or working with that person, and then kind of like a criteria, admissions, and financial aspect. There's a lot of people that we run into that do have these, persecutory delusions and paranoia and hallucinations. And sometimes, that's just something that, say, this certain treatment center is not equipped to deal with. So you're kind of left with, you go to a psychiatric facility because they're kind of, they are equipped to deal with that type of behavior, but maybe not so much equipped to deal with the substance use as well. So if there are some in this area, like the general DFW area, that are more robust, that I guess is doable for the city of Arlington, that would be something I'd love to reach out to. And I say within reason. I don't think we'd be allowed to be driving to like Waco and, north of Frisco and stuff like that. But definitely something that we can at least have a resource for to share with people.
That's a great, I think that's a great segue into our conversation. I know we don't have a lot of time left, so I'll just cue the audience that question from Sean. If you are aware of some resources in that area that might be of service to building up more supports, more collaboration to help those people in crisis, drop it in the chat, or please do unmute and share. Any questions, any feedback for Sean based on this case? Sean, go ahead, Deanna.
Yeah, I was just gonna say that I appreciate all the holistic work you're looking into. It shows that you are aware of the, environmental factors that are at play, and I just wish there was more support out there in terms of behavioral health, because it's all sort of piecemeal. It's a mess.
Yeah, and I know what we're doing now in our unit. We use a kind of our own made up co-responder model. We have crisis intervention specialists now. Here in the next month, we'll have a total of 8 with 8 behavioral health officers. So it's something that we're definitely building on now that we have the resources. I just know a lot of this stuff kind of takes time, and getting everybody to the table and kind of coming up with solutions.
I want to thank you. It's Dr. Miramontes. I want to thank you for bringing this topic up. It sounds like your journey through your CIT and your mental health unit evolution has been one that can inspire others. But the problem you bring up is actually very common, the issue about methamphetamine and schizophrenia. Unfortunately, methamphetamine has been a huge driver of psychotic patients. And you're right, patients do use them to self-medicate. A lot of my patients tell me, well, it gets rid of the voices, at least while I'm using meth. Or it allows me to focus, that I can't focus when the voices are bothering me. But unfortunately, it has destructive effects as well. The other thing I was going to bring up is we also have to be very careful now that a lot of the methamphetamine has a co-contaminant of fentanyl. So they're using meth for the stimulation, and then they get hooked on the fentanyl, and they have to use every day. Instead of bang, bang, crash, crash, they have to use every day instead of every, these cycles of 2 or 3 days. So, and you're totally right. A lot, and especially in the San Antonio area, methamphetamine plays a huge role in this dual diagnosis problem with schizophrenic patients with delusional disorders, and it is quite challenging. So hats off to you all for actually really being this guy's case manager, friend, navigator, support system, because he doesn't have one. And I think this is a great example of how law enforcement can really make a difference in people's lives.
Great comment. And if any others have feedback to share as well, please do use this time to do that. I want to point out the comment from Nick, if you missed it in the chat there, just applauding your effort and appreciating the approach on the social determinants of health, and raising the question if there might be available peer support specialists who can help with that sort of continuity of care and contact, especially as the PD presence sort of wanes over time. A thought to consider.
I just have one comment for Mr. Kincaid. I think that this is an opportunity. For some reason, I feel like the training today, the CIT program, might be something that could be like a segue to help with some of the things that are going on as far as not knowing the resources or not having enough resources. Maybe start the collaboration with other partnerships in your community.
Yeah, I think it raises a question, Jeremiah, you were discussing when we were sort of pre-planning around this case, which is how do you do that landscape scan of the available resources? And I know we're right up on time, but Jeremiah, if you have some quick thoughts on that.
Sure. I mean, it's a real big challenge, right? To know what are the resources, and it looks like you have teams that probably do, reach out, and every city and community often have their like opioid task forces and whatnot. So getting a sense of what's there. Your comment about trying to find out about what harm reduction agencies can offer. I mean, building some relationship with the harm reduction agencies can be really useful because they know the landscape so well and can kind of point out like who's doing what, and also help distinguish away like the less reputable drug treatment providers, which is that's another kind of separate issue. Reaching out there's for folks who are still trying to figure out who the local harm reduction agencies are. The Harm Reduction Coalition has a search function, so you can find your locals and then just talk on the phone or whatever. That can help. Plus, harm reduction agencies can be great as a peer, also as like peer recovery, informally, or start making those connections more formally by way of handing out the kits. So that was all.
Great, thanks so much. Oh, go ahead. I heard a voice and, oh, Jeremiah, I think that was you.
I would just be saying thanks.
Yeah. Well, Dr. Miramonte, coming to you for a wrap up of the key points from our conversation before we close out the hour.
Yeah, so today we had a pretty good, this was actually a really good session for everyone. It actually hit all of our constituent partners. But the CIT program, talking about a low barrier solution to getting access to our folks out there in the world who are struggling with either behavioral health or substance use or both disorders, and how to get them locked into care, and using the 5 legs technique. Basically, we're talking about building a system of care in your community, using your different partners, different funding sources, but working together to solve the issue of substance abuse and also behavioral health issues. Our case today showed a great example of how a law enforcement partner can really partner with a patient from a crisis issue all the way into support, navigation, facilitating them, even some recovery work afterwards, and the complexities of patients with schizophrenia or psychotic disorder and methamphetamine use, and how they had struggled with this client and some of the things they did to overcome those struggles. And it also brings up again this idea of you need to find out what is available in your community, develop a system of care, a communication system, and make sure the funding's going to the right place for the right patients at the right time. So all that was really a great tie-in to the previous discussion that we're having about crisis intervention training. So we thank everyone very much for all their attention today. Great session, engaging, thought-provoking. Now go back into communities and figure out how you're going to do that in your place.
I like that order with which we leave. Well, thanks everyone for joining for today's session. To our presenters, Sean, especially for sharing your experiences and what you learned on this with this case. And thanks to the great Hub team and all of you who are joining to make these sessions what they are. Don't miss that link in the chat from Echo IT, link to the post-session survey and your chance to get that $30 Walmart gift card. We hope to see you at our next session, Thursday, August 10th at 11 a.m. Central. The resource sharing, I will just say this, the resource sharing doesn't need to stay within these Echo sessions alone. If you think of a resource that might be helpful for Sean and his team, feel free to reach out directly to him or relay that message to the CSTAT team and we'll get it to him. We're all in this together. Thanks, everyone. Have a wonderful rest of your week. We'll see you in August. Bye-bye.